Um, this is a presentation on the elbow examination. How do I change the slide? So just to briefly run through the anatomy, but this will be covered in another talk. There's three bones that make up the elbow joint, the humerus, the ulna, and the radius. And there's three joints within the elbow joint formed by these bones, which allow for the flexion, extension, supination, and pronation. These are all kind of held in place by multiple ligaments. So there's lateral collateral ligaments, medial collateral ligaments, and an annular ligament around the radial head. Then there's muscles that surround these. So there's large movers of the elbow, so the biceps and the triceps muscles, as well as muscles that assist with pronation, supination, and movement of the wrist. And then importantly, there's three main nerves that cross the elbow. The radial nerve on the lateral aspect, the median nerve through the middle, and the ulnar nerve on the medial aspect. So before starting an exam, it's always important to make sure you take a proper history. And then especially when examining the elbow, it's important to just rule out any spine or shoulder pathology that may be referred to the elbow. Ensure the patient's adequately undressed and make sure to compare both sides. So to begin, let's cut off a little bit there, but to begin the examination, you want to have a look first. So have a look at the patient's resting position, see which side's affected, and compare it to the other side. Whilst having a look, you should assess the carrying angle, which is the angle between the shaft of the humerus and the shaft of the ulna. In males, it's about 5 to 10 degrees, and in females, it's 10 to 15 degrees. It's important to note that this can only be assessed when the elbow is in full extension, as once the elbow starts flexing, then it comes in more of a varus. Whilst having a look, you look for signs of edema, ecchymosis, atrophy, scarring, angular deformity, and other asymmetrical findings. And if there's effusion, it might be due to one of the various things that I've listed there. And also to consider
the owner of a white Isuzu 1C24NE, please come to front reception.
And then if it's muscle atrophy, consider whether it's chronic from inactivity or nerve wasting, but also be careful that you may be comparing a non-dominant side to the dominant side, and it may appear smaller, but may be completely normal. Then you would have a look at the muscle bellies, so of triceps and biceps muscles, to see if there's any shortening or asymmetry. And the presence of an ecchymosis might suggest an acute tendon rupture. You might also look for some nodules, like tophi, and then also of note is there's an isosceles triangle which is formed from the olecranon process, the medial and lateral condyles, and when the elbow is flexed, that's when you get that triangle, and when it's fully extended, these should all line up in a straight line. If they don't, then it might suggest a effusion or a fracture or dislocation. The next step is that you want to feel the actual joint itself, so have a feel to see if the temperature's changed, which may suggest an inflammatory response or an infection. Palpate the radial head, and this can be done with passive ranging of supination and pronation to feel that it's moving smoothly within the ligament. You also want to palpate the olecranon process, the medial and lateral epicondyles, the soft spot, which is an area between the lateral epicondyle radial head and olecranon and the lateral aspect, which is a small indentation which allows you to feel the joint space. This is also the point where, if there's an effusion, you'd lose that dimple, and also the point where you'd do an aspiration if needed be. And then also feel for the biceps tendon, which we'll go in a bit more detail in a sec. Then you move on to moving. So in the elbow joint, full flexion is up to 145 degrees. It goes up to neutral, which is 0. Pronation and supination go roughly about 75 and 85 respectively. And looking at the diagram, it's measured from neutral position. During this kind of assessment, you feel for any crepitus, pain, and mechanical symptoms that may suggest cartilage irregularities or loose bodies. Also to note, when you're moving the joint, if there's a soft endpoint, it might suggest a swelling or capsular tightness, whereas a hard endpoint suggests maybe an osteophyte or a loose body. Now moving on to the special tests, they've kind of been classified depending on what pathology you're specifically looking for. So if there's suspicion of a medial ulnar collateral ligament injury, in particular the anterior bundle, which provides most of the support, there's two maneuvers you can do. One is the milking maneuver, which involves flexing the elbow to greater than 90 degrees and also flexing the shoulder. The examiner then pulls on the patient's thumb while the patient's forearm is supinated. And if the patient experiences any apprehension, instability or pain over the medial aspect of the elbow, it's a positive test. The other test that you can do is a moving valgus test, which involves the patient either sitting or standing and the shoulder abducted to 90 degrees. The elbow is then maximally flexed and then modest valgus stress is applied to the shoulder, which is externally rotated to the limit while maintaining a constant valgus stress on the elbow. And then the elbow is kind of quickly extended to about 30 degrees. And if the patient experiences any pain on that medial condyle, it's also a positive test. You can see the sensitivity of these tests are quite high. Then moving on, so if you're suspicious of epicondylitis, to assess the lateral aspect, there's a Molesley test, which involves essentially resisted movement against the middle finger with palpation of the lateral condyle. If there's pain associated with this, then it's suggestive of a positive test. Alternatively, you can push against resisted wrist flexion with the elbow in full extension. And interestingly, grip strength, if it's lateral epicondylitis, is decreased by 29% when the elbow is extended compared to flexed. Lateral chair test is another way you can test the lateral epicondylitis, which just involves essentially lifting a chair with straight arms. And then if it's suspected that it's medial epicondylitis, then you can do very similar, but in this case you have the patient resist wrist flexion with the arm in forearm pronation. Moving on. So in the suspicion of tendon ruptures, so if there's a suspected triceps tendon rupture, they can do what they call a modification of the Thompson test, which is what they use for the Achilles tendon, which basically involves the patient resting their arm on a bed or a table with the forearm hanging freely over the edge. The tricep is then squeezed and you observe for any slight extension. If this is absent, then it's suggestive as there may be a rupture. In regards to the biceps, there's a couple more tests. So they can do the hook test, which you can see in the image on the side there, where the elbow is flexed to 90 degrees and supination of the forearm. The examiner then attempts to hook the tendon on the lateral side. If the tendon is palpable but there's pain, it suggests that there may be a partial tear. But if there's no tendon at all palpable with the hook, then it's suggestive of a complete tear. There's also a similar test to the modified Thompson test, which is just a bicep squeeze where the elbow is placed at 70 degrees flexion, slightly pronated and rested on the patient's lap, and the muscle belly squeezed to observe for increased flexion. There's a couple more. So you can do a biceps crease interval, which essentially you just measure the crease when the elbow is flexed, and then you measure the position where the biceps tendon most sharply turns towards the antecubital fossa, and you measure that distance with a threshold of 6 centimeters, suggestive of a tear. And also you can do the biceps crease ratio, which is assessing to the unaffected side. And then passive forearm pronation test, which is just observation whilst you passively pronate and supinate the forearm, observing the bicep to shorten and lengthen if it's intact. If there's concern about posterolateral rotator instability, there's a couple tests. So there's the lateral pivot shift test, which isn't all that sensitive, but is visualized there on the right image. Essentially, the patient lies supine, the shoulders flexed, the hand is supinated, and you commence in full extension of the elbow. And whilst flexed, the valgus and rotational force is applied, and apprehension is usually felt at 40 degrees flexion of the elbow. Alternatively, you can do the posterolateral rotatory draw test, which is essentially the resting position is as seen on the side, that instead of moving the elbow joint, force is just applied upwards, and apprehension is felt. More sensitive though, so essentially a push-up. which asks patients to lie on the floor and push up from the ground, and usually as they're pushing up they feel apprehension in the elbow joint, or a chair push-up test, which is also very similar, just using upper body to push up from a chair. But I guess an easy one is the tabletop relocation test. So you ask a patient to push down on the table, as you can see on the right there, and as they push down on the table, as they move their chest towards and bend the elbow, they'll feel apprehension in that lateral aspect of the elbow. This can be then done again with the examiner putting their thumb over the radial head, and which should relieve the symptoms. If both those things occur, then it's considered a positive test. If there's concern about the radiocapitellar joint pathology, so synovitis or OCD, then the examiner essentially does supination, pronation whilst applying an axial force. If there's pain or crepitus, that's positive. And finally, in terms of special tests, so from the slide earlier, looking at the ulnar, median and radial nerve, they can all be entrapped within the elbow. Suggested findings on examination. So with the ulnar nerve, you want to have a look, if you're just palpating the whole course of the nerve along the medial aspect around all the way to the hand. Things that give away that it's a bit higher up and not down at the wrist is that if the dorsal sensation of the hand is intact, then it suggests the pathology's the entrapment's a bit higher. And also if you look at the hand, if it's in the cubital tunnel, which is at the elbow, you expect less clawing at the 4th and 5th digits. And this can be assessed with the elbow flexion test, which you can see on the right, where a patient is fully flexed at the elbow, 90 degrees extension at the wrist, and they hold that position, and after about 30 seconds, if they experience nerve symptoms, suggestive of a positive test. In regards to the median nerve, it's can be trapped also in multiple places, but things that can help you differentiate it is if the palmocutaneous branch sensation is lost, it suggests it's unlikely to be carpal tunnel and more likely to be entrapped further up. And this can be assessed over the pronator compression test, which is the image on the top left, or resisted pronation and supination, which would suggest that it's entrapped in the pronator teres muscle. And then the radial nerve can also be impinged in multiple locations, and suggestions that it's above the elbow is if there's weakness in wrist extension. And another sign to look for is if the sensation of the superficial radial nerve is essentially intact or lost, then it suggests that it's the lesion's above the arcade of Froese. And then on the side you can see the rule of 9, which is essentially saying that if you palpate at 1 or 2, you would expect radial nerve lesions to have symptoms there, and if you palpate at 5 or 6, you expect median nerve, and if you palpate the other ones, you wouldn't expect anything. And they're the references.